Just as you're wrapping up your lunches and conversations, I wanted to come on and introduce the next session. My name is Lama Abdullah, and I am a medical student at the University of Toronto. Really excited for this next session, which will be called Trauma, Identification, Prevention, Protection, and Healing. As we mentioned before, feedback for the session and the conference can be provided directly after or digitally after the conference with a Google Forms survey, which will be distributed. And mental health resources are available on the muslimmentalhealth.ca website. The goals of this session are to identify the most common psychological and behavioral reactions that individuals and communities can experience during traumatic events, for example, vicarious trauma or survivor's guilt. Demonstrate the basic skills of psychological first aid to mitigate distress and promote recovery in individuals and communities during traumatic events. To provide culturally and spiritually responsive strategies through case-based discussion to prevent and break the cycle of intergenerational trauma. To review actions necessary to protect the psychological health of mental health providers, and to discuss trauma-based cases and explore practical approaches towards facilitating post-traumatic growth. It gives me great honor to welcome our two guest speakers. We have Dr. Omar Reda joining us virtually. Dr. Reda is a board-certified psychiatrist, a Harvard-trained trauma expert, and the author of many books, including Untangled and The Wounded Healer. He is the founder of the Healing Trauma Institute and has extensive experience and expertise caring for refugees and in the field of humanitarian mental health. He is a big advocate for family bonding, youth empowerment, and Muslim mental health. Our second guest speaker is here in person, Dr. Zoë Thomas. She is a psychiatrist at the Jewish General Hospital in Jijage or Montreal, and an assistant professor at McGill University since 2018. In 2019, she launched the Trauma-Focused Therapy Program, a specialized psychotherapy program to help people overcome the impacts of complex trauma through group and individual therapy. She has been involved in anti-racism education initiatives within her department. She also leads the Adult Psychiatry Day Treatment Program. So give me a round of applause in welcoming Dr. Zoë Thomas and Dr. Omar Reda.
Do I control the slides or is it okay? Hi, Omar. Do you see me? Yes. Okay, good. This is us. السلام عليكم. اسمي زوي. أنا طبيب نفسية من مدينة مونتريال. تشرفني هذه الدعوة بأن أكون هنا معكم. شكرا كتير for having me. I feel really privileged to be here. And if it's مش مشكلة, I'm going to switch to English because I only أحكي عربي شوية. And what I eki is from, I spent some time in Palestine many, many years ago, where I volunteered in the West Bank and East Jerusalem. And so that's me. I'm Jewish and I'm a white settler here in Canada. And I mainly do trauma-focused therapy and mainly with survivors of complex trauma and so child abuse survivors. Ooh, it's weird. You hear yourself double. Omar, if you want to introduce yourself.
Assalamu alaikum. Hopefully you can hear me okay. It's really a pleasure to be with you. Omar Reda, I am a psychiatrist originally from Libya and I practice in Colorado. Allah subhanahu wa ta'ala put me in a position of being an asylum seeker and then going through some visits to refugee camps. And alhamdulillah, I found lots of healing in Islamic psychology and trying to, inshallah, use the Quran and Sunnah as our healing tools. It's really a pleasure to be with you today.
Amazing. Okay. Ah, that's better. How do you hear the double? Is this better? Okay. I know it's so disconcerting because I hear my house still. Is this one? Hello? Oh. Hello? Okay. It's okay. Okay. Better. Yeah, it is actually. We'll make do. Okay. Great. Okay. So just before we start, I just want to acknowledge that this conference, this talk is taking place on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat. And I was very actually shocked to learn that this whole city of Toronto was actually purchased by the colonial government for about $68. Isn't that incredible? So thankfully, at least there was a lawsuit and the government had to pay back 145 million. But I guess we acknowledge the land that we are on and also kind of acknowledging that all anti-colonial struggles are connected right throughout the world, which is very relevant right now. We don't have conflicts of interests, Omar and I. Lama already told us the learning objectives, so I'm not going to go over them again. And before we start, we felt that we needed to, in some way, acknowledge the elephant in the room. Because usually when I talk about trauma, I always talk about the fact that just talking about trauma in and of itself is generally activating because most of us have our own trauma histories, right? And we may or may not have processed and resolved them. And so it's already lights up all those networks for us. And talking about trauma as we're witnessing genocide unfolding is even more activating and can bring up these completely normal feelings of helplessness, shock, exhaustion, or feeling like a neglectful bystander, right? A lot of guilt and responsibility and feeling like we're not doing enough. And so I think we just want to name that as we move through this talk together. And that's going to kind of be a thread, is that really what we're going to be talking about for patients and for healthcare providers is kind of two sides of the same coin. And really that we're all kind of human in this shared experience of being confronted to violence together. So yeah, I just want to name that. And I think we're definitely willing to, if people have reactions or thoughts in the question period, we can talk about that. Omar, did you want to introduce Faris?
Yeah, sure. So this is a 16-year-old boy from Syria. He came to the United States in 2016. Unfortunately, mom and dad were separated during them leaving their hometown. And unfortunately, because of marriage dynamics, most likely they're gonna divorce. Faris is the oldest boy. There are 4 children in the family. He's the second oldest, so he has an older sister and 2 younger brothers. And the sister, she said she has nothing to do with Syria, with Islam, so she wants only to speak English. She doesn't want to pray. And the 2 younger brothers, they kind of staying in the shadow of Faris. And he's very worried that maybe they are struggling with some features of autism. And unfortunately, he went through lots of bullying and Islamophobia when he came because he could not speak the English language. Given that, mom basically is the foundation of the family, she's trying to hold everybody together while also taking care of her own mom. So the grandmother is living with them, and she witnessed her own son die in her arms. He was killed by snipers during the 2011 Syrian revolution. So the grandmother has lots of PTSD that she's acting out, if you like, in the form of trying to control, the children and the mom, and she tried to reconcile between the mom and the husband, which caused lots of tension in the whole family. So I just wanted to bring, a scenario of a young boy who can be labeled as, somebody with anxiety, somebody who's oppositional defiant. And if we just focus on Faris, who wants to be a boxer, but his mom wants him to be a physician, she said, if you become a boxer, you're going to be a disappointment for the whole family. If we only focus on the child, I think we're going to not really do comprehensive healing for this family. So alhamdulillah, we believe in our tradition that healing is both a family affair and also communal affair. And we're going to talk about that later on using examples, inshallah, from the Quran and Sunnah. Thank you.
So maybe a couple questions to ponder. We're going to talk first about just trauma presentations, which I'm sure many of you are familiar with. And I guess when we're working from a trauma lens, we really don't see any of these presentations or symptoms as pathological. We just see them as very normal and predictable responses to abnormal experiences, right? It's funny how trauma and PTSD has become like a clinical issue, but it's actually not at all a clinical issue. It's a social issue, right? It's an issue of violence. So it's interesting that it really intersects with our clinical realm, but ultimately we're actually talking about social problems. These are usually the elements, right, that we're thinking of when we're thinking about traumatic events, that there's violence, that people's lives or integrity are threatened. And generally, I work a lot with interpersonal trauma. There's also natural disaster trauma, of course, but generally it doesn't have the same kind of effects in terms of psychologically. There's these elements of boundary violations, of abuses of power, absence of choice, ultimately resulting in the experiences of helplessness, shock, terror. And I don't think I need to say this really to this room, but again, trauma and violence are not equally distributed. They're happening within the context of colonial, patriarchal, ableist, white supremacist society in which certain identities are marginalized and oppressed and are facing much higher rates of violence and trauma. And so this really, I guess, informs how we're thinking about responding to these presentations. Yeah, there's this often secrecy around trauma, or we maybe don't think about it or talk about it enough in our clinical practice. And there's kind of this sense that, oh, maybe just with time, things will get better. This is a diagram from Janina Fisher, where we kind of see that all of these different symptoms are very predictable and normal responses to traumatic events. And I guess if we're working from a trauma-informed lens, we're not seeing these as discrete issues. We're not saying, oh, you have your depression and your panic attacks and your GAD and your social anxiety, your eating disorder and your substance use issues as, discrete diagnoses. We're seeing these all as normal outcroppings of abnormal events that are often far-reaching, that are often not necessarily directly connected to the traumatic events. This is just another way of representing it in the sense that we know that these experiences impact at the very core of spiritually, right? Who we are, how we see the world, how we see others, our capacity to trust, our capacity to believe that we can be someone important. So this is from Filidi, who did those seminal ACE studies. So looking at definitely child abuse and violence as these hidden epidemics, right? That time doesn't heal these wounds, but conceals them, right? And they often show up in these sideways ways. And often then what can happen is that even though involuntarily some of these interpersonal patterns can get kind of reenacted and replayed out within the family, the community, the nation, right? There's this kind of ripple effect where trauma doesn't only affect one individual, but ends up then having an impact on the entire community. And often when we are working clinically with trauma clients, generally there's many pitfalls because generally trauma survivors present with justifiable mistrust, right? The opposite would be weird, right? If you've been betrayed by the system, by people who were supposed to care for you, like, why would you trust any authority figure? That wouldn't make any sense. And generally, for many people who've been traumatized, expressing your needs directly was absolutely unsafe, right? You might have been met with violence or with dismissal. So often trauma survivors will present their needs in much more indirect ways, which can then lead clinicians to start feeling incompetent or helpless, burn out, right? And then we can get these patterns of institutional re-traumatization where we end up labeling, blaming the patients, and kind of double down on wanting to, emphasize our recommendations. I'll just give it over to Dr. Reda if you have some thoughts before we move to the vicarious trauma piece.
Yeah, thank you. I love the fact that we actually are two psychiatrists, but we are not using the medical model. So there was lots of emphasis on only biological interventions, but I'm very glad that we are talking about the soul and our spirituality, because alhamdulillah, and in our religion, we have lots of healing that comes from that. And, we can talk about many definitions of trauma, but I like the definition from SAMHSA, which is the Substance Abuse and Mental Health Services Administration here in the United States. They said trauma is three things that start with the letter E. So the first one is the event itself and what happened to you. And then the second thing is a subjective experience. So what's your interpretation of what happened to you? And the last one is the effects. So the relational impacts and the ruptures that will happen when trauma will reenact itself. Unfortunately, there's lots of secrecy, like you said, Zoe. And I believe the Muslim community also has lots of stigma when it comes to mental health. And this is very unfortunate because it's really against the traditions of our beloved Prophet ﷺ. He was somebody who expressed his emotions publicly. He was somebody who was a safe space for the rest of the companions. So the Quran and Sunnah are full of verses and, many tools and skills that we can use in order to break the cycle of stigma. But the last thing I'm going to finish with is, I love how you said, PTSD is a social issue. I would also add it's most likely a moral issue. Right now, just seeing how humans can hurt other humans really is causing us to have a moral distress rather than a mental disorder. So I'll stop here, but thank you.
Absolutely. Which really ties into our next section, which is more about vicarious trauma, which truly is an occupational hazard. It's unavoidable. It's the natural consequence of caring for others, right? And it's this transformation that occurs within us as healthcare workers as we engage empathically with not only horrific details, graphic details of, horrors of human violence, witnessing cruelty of humans against one another, but also the deep feelings and kind of relational reenactments that happen when we're facing, helplessness and shock and rage, and how this kind of permeates the clinical space. So vicarious trauma, we talk about it for clinicians and health professionals, but it also happens, we were talking in the posters about imams, clergy, journalists, first responders also have vicarious trauma. And I think right now we can think also about the whole entire community, right? Witnessing events that are happening. It's really a process, so it's very insidious and cumulative. And I think similarly to trauma, maybe I kind of use this metaphor of a teacup, right? If you have one traumatic event, it's kind of filling your teacup a little bit, but not too much. But then you have another one and another one and another one. And eventually the cup spills over, right? And it might be the last thing that happened didn't even seem that dramatic, but there's this kind of building block effect where it's filling up progressively. And this also happens for healthcare workers in terms of, our vicarious trauma load over time. And I like to emphasize also that it's not only, like you hear these very graphic descriptions of details that are very perturbing, and maybe that comes back to you, later after you've left the clinic, but it also includes our strong feelings. And this ties into what Dr. Reda was saying, some of the moral injuries of kind of bearing witness to injustice in this way. Here's some of the risk factors, which you can read about on your own. I just want to say personal history of trauma is a bit of a caveat, because definitely if you've worked on your own trauma and you've processed it and you've made sense of it and there's been some post-traumatic growth, then it might actually be an asset that you're more able to empathize and connect. But definitely if it's still very raw, that can be a risk factor. It reminds me also of that poster we saw about the imams, like in terms of overextending yourself and doing too much, that's definitely a risk factor. You can also read through these warning signs after, but basically just to highlight that it's very similar to the symptoms that we see in post-traumatic stress, right? Where we have intrusive symptoms of maybe dreams or intrusive thoughts or memories, even flashbacks. But then also this kind of existential questioning, profound feelings of guilt, and kind of cynicism and moral questioning. And then there can also be avoidance, right? That we face ourselves as clinicians because it's so overwhelming. And this kind of ties into survivor guilt, which is kind of, I guess, just an aspect of vicarious trauma, which is very common and kind of involves this emotional distress and this sense that we were responsible in ways that we generally weren't, that there was something we could have done to have prevented it, right? Which is very similar to trauma survivors' experiences. Everyone will always say, negotiating with the past of what could I have done to possibly prevent this? And this often happens for people who survive or who are witnessing vicariously. So I'll pass it back to Dr. Reda for any thoughts before we shift to the healing part.
Yeah, I would say I like a statement by Dr. Gabor Mate. He said, trauma is not only what happened to you that should not have happened, like, abuse or Islamophobia or hate, but it's also the things that did not happen to you that should have happened. For example, safe space or having somebody that you trust. And I think right now there is lots of soul ache in the Muslim community because there are things that have been censored that we don't talk about, and we feel like our story has been dictated on us by others. We don't have access to the podium. Unfortunately, the story that we see in the media is quite distorted, and it leads to lots of helplessness, hopelessness, and survivor guilt. So I see that very, very commonly in the Muslim community these days. And I'm very, really honored that finally I'm working again with Jewish colleagues. This is the first time since October 7 that I'm working with a Jewish colleague. And this is what we want. We don't want to see our Jewish brothers and sisters as the enemies, because we know that we are coming from a humane approach, that all of us, we believe in the same God, and all of us, we need really to look at our communalities rather than our differences. But something that you said, Zoe, is about the children, which I really feel for, because many times when they express their trauma, we don't see it as traumatic. And many times we give them labels as spoiled or entitled. But really, many of our children are going through difficult time trying to process what's going on and make meaning out of suffering. And they have free access to the media. So they see videos and they see pictures that no child should really see, imagine what's going on inside Palestine. But I would say have lots of compassion right now for the children, have lots of flexibility for the children. Don't only focus on their academic achievement, and try to use the play and art. I do that a lot with my 3 daughters. And also when you're working with the trauma survivors, make sure that you don't force them to speak when they are not ready to share their trauma story. Make sure that you are ready to listen when they are ready. And if you are not ready to listen, make sure that there is some kind of mechanism for you to send them to somebody else. And so make sure you don't open a wound that you are unable to close, and make sure that you don't open your own wounds by listening to the stories of others.
Shukran. Okay, so now we'll talk about a little bit the healing. And I love these 4 pillars that are from Dr. Reda that we kind of collaborated with both of our expertises to kind of think of these 4 pillars: safety, connection, justice, and beauty. And so thinking about how we can actually respond using these threads. So safety. So Stephen Porges actually says the treatment for trauma ultimately is safety, right? And we can all agree, because basically the experience of trauma is of unsafety, is of danger. And so ultimately that's what we're striving for, is giving people an experience of safety. But Judy Herman kind of defines this stage-based model, which can be very helpful for us as clinicians, because often when we're entering into the clinical space with trauma survivors, it can feel a bit like this storm, it's so much and we don't know where to go. And so this is a little bit of a kind of stepwise approach. And I guess the first stage is really about building safety and stability in the present. This is often the longest stage. Really, it's about kind of building enough of a solid foundation in the here and now. And then once that's done, then you can go back and actually work through the memories from the past when, the horrific traumatic memories, taking the sting out of them, metabolizing them, digesting them. And then throughout, there's kind of this integration and reconnection stage, which is really about post-traumatic growth, which is really about, I guess, reconnecting. Who are you? Who do you want to be? What's your purpose? What's your sense of meaning? I think there's a lot of room for spirituality also in stage 3. But I guess essentially stage 1 is a little bit of our psychological first aid principles. And I always tell people slow is fast, right? Some people want to rush to the finish line. If I can just tell my story, then I'm going to be okay. But if we don't have enough stability in place in the present, we know that that can actually be re-traumatizing. So this is what we mean by kind of stage 1 safety, environmental safety. So really, do people have a status where they're in the country that they're living in? Do they actually have stable living conditions? Are they in abusive relationships? Because then if they're coming to you for help, but they're going back and facing violence at home, you're undoing essentially the work. So these are kind of the priorities. Similarly with physical safety, is there addictions or eating disorder issues that are so intense that they need detox or that they need medical care for that? And finally, this concept of emotional safety, which is often where we do most of the work in stage 1, about how do we find ways to actually calm our bodies, modulate intense emotions, set boundaries. And I really loved Dr. Mona's presentation this morning, thinking about so many ways that actually already in Islam, there's so many practices that are kind of focused at building emotional safety. And again, part of this kind of psychological first aid, this idea of self-care, which is, talked about constantly, but we often think about, just sleep, routine, eating, exercise, sex, those kind of important self-care activities, which generally trauma survivors really struggle with, because they were generally, when we're dealing with child abuse survivors, you are not shown that your needs are important, right? Or your caregivers did not even know how to identify or address their own needs. And I think, again, this is layered also into structural inequalities, right? Where maybe there's internalized racism, internalized sexism, or ways that you might not feel deserving of actually taking care of those basic needs. But there's kind of this seesaw, right, between we know that generally symptoms are much higher when the self-care is down, and that the only way that the symptoms go down is if we actually prioritize some of the self-care. The next couple slides are just a couple psychoed slides that I often talk about with patients. It's very neurobiologically rooted, which may or may not resonate with different explanatory models, but sometimes it's helpful for people to kind of understand what's happening in their nervous system. I guess evolutionarily, we are similar to animals in the sense that we have a little brainstem. And when we're faced with a threat, so let's say if, suddenly there's a giant bear that comes raging through the conference room and is attacking me, my first, within 12 milliseconds, my brainstem is going to send signals to the rest of my body to start pumping my heart, sending lots of oxygen to my large muscles so that I can prepare to mobilize to respond to this threat. And if I'm able to flee, I have 100% chance survival, right? But if I'm backed into a corner, then maybe my next kind of line of defense would be to fight. But if it's me versus a bear, I'm unarmed, the odds are not in my favor. And so the nervous system will kind of make this very quick automatic calculation about what is the highest chance of survival. And then if, okay, you will not win against this bear, I will go into freeze, which is again, this state of high activation in the body, the heart racing, there's a lot of tension, there's a lot of adrenaline coursing through there, but it's also this state of paralysis, right? It's being completely still and completely mute so that the threat might pass. The bears don't have great eyesight. If I'm not making a noise, if I'm completely still, maybe it'll just pass. But freeze is so taxing for the body because it's like this tsunami of adrenaline kind of crashing into this wall, right? It's like you have the pedal full on the brakes and full on the gas at once. So actually we then quickly move into feigned death, which is actually the opposite. The system shuts down, the heart rate slows, temperature drops in the body, the muscles go limp. And I guess why this is important is that generally the immobilizing responses of freeze and feigned death are the only responses that are really accessible when you are a child, right? Because you can't actually flee. You're dependent on your caregivers. You can't actually fight back. And so this kind of leaves us with this sensitized nervous system. There's basically like long-standing effects of this. And we kind of think of this according to the window of tolerance. So this is, again, when we're thinking about how people are kind of regulating their nervous systems, that generally when you're in the face of a threat, in our window of tolerance, we're connected to the present, we're connected to ourselves, to others. We're able to identify our emotions, our feelings, our body sensations. But then if there's a threat, we will either move into hyper or hypoarousal. And in those moments, it's like our nervous system is actually time traveling into the past, right? And generally what happens is that it's kind of, we see this in a lot with trauma where people are having these really intense responses in the here and now to triggers that maybe for other people might seem minor, right? And so something has kind of alerted their amygdala and whoops, they're in hyperarousal or hypoarousal. And so we can help people build awareness around this, around what it feels like in your body when you're outside of your window of tolerance, and then helping them actually come back into their window of tolerance through grounding. And I liked, again, Dr. Mona had lots of ideas of how we can use even Islam as for grounding, right? And really what we mean by grounding is like a set of techniques to bring you in the here and now, right? Where there is enough safety. Maybe in the past there wasn't enough safety, but if you're able to bring your nervous system back to the here and now, over time that window of tolerance actually widens. So we generally use a lot the five senses because that's kind of orienting us to the present. So looking around, naming colors in the room, maybe, drinking, having a sip of water, feeling the ground under your feet, squeezing your hands. People can also have objects that they use as grounding objects or mental strategies. So that's kind of in terms of building safety, right? Kind of building those building blocks of here and now stability. And connection. So we know that safety is first established relationally, right? We're very different than sea turtles. You know about sea turtles, that they're born, they hatch, and then immediately they just go into the ocean and they have everything they need. They don't need a caregiver. They're set for life. Us, we're completely dependent on caregivers, right? And so safety is established relationally, and therefore healing from violence also happens relationally, right? There's this bind of interpersonal trauma, especially if it's in the context of child abuse, where the person that you depend on the most is someone that you can't trust, right? That is an untenable situation, to be terrified of someone that you need. It really sets up this paradox for later relationships. And I think that there's lots of ways that then this can get reenacted, right? Where it's you need to reach out to the healthcare system, but you're discriminated in that system. So there's this paradox that ends up happening. And so we often think about trauma and violence as very isolating experiences. They fester in shame. They kind of build up in silence. And that there is this antidote of connection, both within the therapeutic relationship and then also outside of it, right? And I guess for us as clinicians and therapists, it really takes this unlearning, this constant process of curiosity, of understanding our own blind spots, our own intersectionalities, and how, we might make people feel unsafe or safe, and what maybe we can completely be in solidarity with maybe the gender part, but then are we really queer inclusive, or have we done all our anti-racist or anti-colonial unlearning, or all of these things? So it's constant learning. And I guess definitely when we're working from a trauma lens, we are completely relinquishing the role of the expert and wanting to be in collaboration with people. Yeah. When we think about mitigating vicarious trauma for healthcare workers, sometimes it can be helpful to have a little bit of buddy, someone, who has your back, who you can actually talk about. They found that this was actually quite effective. Justice, the third pillar. So it's interesting because here we're actually diverting a bit from the idea of Judy Herman's new book is all about how the justice system is completely not trauma-informed, and, that it generally doesn't lead people to feel a lot of recognition or justice. So we're actually talking in this context more about how do we prevent intergenerational trauma, right? And that sometimes through not perpetuating unconsciously things that have been done to us can also be a way of, I guess, advocating for justice for future generations. There's this idea of the 3 heartbreaks of trauma, right? There's these layers of betrayal. The first thing is that the trauma happened. It should never have happened. But then it leaves this legacy of symptoms that we talked about in the first part. And then it often unconsciously gets perpetuated, right? Because maybe the ways that we were treated get internalized, and then there's ways that then we treat people around us similarly. So we thought we'd just say a few words about parenting as a trauma survivor, just in this vein of how do we prevent or mitigate intergenerational, transgenerational trauma? And I think what, most of my patients who are parents and are also trauma survivors, it's a very bittersweet experience, right? Because basically it requires giving to your child something that you didn't get, right? And so there's kind of this injustice in it. There were, as Dr. Reda said, the things that should have happened that didn't happen. Maybe that emotional care or those emotional needs that you were so needing, you didn't get them, and now you have to give them to your child. It's kind of this that it can bring up these conflicts, right? And I guess that is kind of part of parenting as a trauma survivor, is actually this parallel process of actually repairing between yourself those unmet needs of your inner child. There might be these disavowed parts of yourself that you feel ashamed of or disconnected or angry with, embarrassed of. And how do we actually repair that relationship within ourselves so that we then don't impose it to the children? Thinking again about this window of tolerance, right? And when we're outside of our window of tolerance as parents, then we might be more in this kind of adaptive child energy where we're actually back in the past, not in the present. Generally, people, there's a very black and white rigid thinking, a lot of tension in the body, more harshness, versus parenting, with our full prefrontal cortex on as adults. It's more nuance, more realistic, more humble. Some practices, I guess, for parents. And one of these practices is validation, right? Which is often really difficult because if you've grown up in a context where your experience was not validated, and then maybe also societally where your experience is erased or invalidated, it can be actually very hard to validate your own emotions. But in order for parents to be able to validate their kids, it requires this first step of validating yourself. Here are just some strategies that people can use, I guess, institutionally, just thinking about the mitigating vicarious trauma and having justice within our healthcare system, which can often seem like a futile enterprise. And then finally, beauty. So, yeah, this is, the wind does not break a tree that bends. And so this is where this kind of idea of resilience comes into mind, of how people bounce back from adversity. Many people don't love the term resilience because it feels like it's like the onus is on the survivor to somehow like blossom after there's been this terrible violence inflicted upon them. So some people prefer the term resistance. But there's this sense that there can be growth from traumatic experiences, and there's a lot of literature supporting this, that actually more than just bouncing back, we actually can gain something from these experiences. Resilience is not associated with no distress. Generally, there is distress, but it is universal. And this kind of brings us also to vicarious post-traumatic growth, for us as clinicians, because again, it could be like, how are we resilient in the face of being in proximity to all of this violence and trauma? But definitely it helps us gain way better relationship skills. Like, you are managing conflict all the time if you're a trauma therapist, and so you become much better equipped at resolving conflict. And there can also be this increased sense of gratitude and sensitivity. And we do a lot of group work, and we definitely see this in our groups in terms of the level of attunement, of capacity for non-judgment, is pretty amazing in trauma survivors. So just highlighting that. And I'm going to turn it back to Dr. Reda for your thoughts on these 4 pillars of safety, connection, justice, and beauty before we open it up to the audience.
Yeah, thank you. So I would start with safety. I think many times we believe, in our own interventions, and we think we need to dictate them on folks who maybe are not ready or they don't share the same belief system. So I see people with good intention. They go to refugee camps and war zones, and they try to dictate specific interventions on people, and many times these interventions are hostile and invalidating, and they get dismissed. Sometimes that people are even asked to leave the scene because they are doing more damage, even though their intentions are good. So I remember, my supervisor in the Harvard program for refugee trauma. He said, Omar, he has a refugee clinic in Boston, Dr. Richard Mulika, and he said he have already treated about 10,000 patients. And he said in maybe 10 of them, they needed like EMDR or, trauma-focused CBT. He said most of them, they heal through a human connection, through honoring the trauma story and making meaning out of it. And So that's one thing I want to talk about. And sometimes fancy interventions in the middle of a war zone or a refugee camp can be considered like a psychological luxury that maybe it's not the right time or the right space for that. Many people in Palestine, they're going to heal through collective healing. Many times we don't have the enough expertise or enough resources for individual healing. So hopefully we can support our brothers and sisters in their collective healing, inshallah, when the war is over, and we will be part of the healing process. And also, I would encourage you to have as many tools in your toolkit as possible. So don't only be too rigid with your own intervention or your own small area of expertise. Many times what we actually end up doing is not evidence-based practice. It's really practice-based evidence. We start with a practice. We build an intervention with the community. We have a student attitude. We are very humble when we work with these communities. And many times, alhamdulillah, together we can craft an intervention that will be more effective. I know many times the donors don't like that because we don't have enough quantitative data. But the quality of the intervention many times is in the form of relationship repair of ruptures and family bonding, and how to maybe strengthen the marriage. And this is what the focus of the Prophet ﷺ and the rest of the Anbiya. And we know trauma was not necessarily mentioned in the Quran. There was no mention of the word sadma per se, but sadma was mentioned in the hadith when the Rasul ﷺ, he said, إنما الصبر عند صدمة الأولى. So when people go through grief, they need to show, self-discipline and show patience, especially the first time they hear the quote-unquote bad news. And with Allah, there is no bad news. We know people who die, inshallah, they go to paradise, and they are in a much better place than we are. But here we are struggling with our own emotions, our own survivor guilt and vicarious trauma. And I think the best thing we can do is to really take care of ourselves and our small families and our small community, and build that safety. Because the first thing Rasulullah did when he entered Mecca, he said, "Man dakhala darahu fahuwa amin." So if you enter your house, you deserve to feel safe. So our houses should be places of safety. He said, "Man dakhala al-masjid fahuwa amin." If you enter the mosque, you should feel safe. So our masajid, our community centers should be places of safety. "Man dakhala dar Abi Sufyan fahuwa amin." If you enter the house of a community leader, you should also feel safe. So our community leaders, our faith leaders, our imams, need to be sources of safety. And we need to be sources of safety for our family, which means the Muslim house is a safe house. There is no domestic violence or anything like that, inshallah. And just alhamdulillah, we have a few more weeks of upcoming holiday. I would encourage everybody in the room, inshallah, to focus on their family and make lots of dua for the brothers and sisters in Palestine. At the same time, don't forget that you're a small community here. I remember, subhanAllah, when I went through my own PTSD, going through the war in Libya in 2011, the four things that I was able to heal my trauma through is to lean on my faith, and to love my family, and to practice gratitude, and engage in acts of service. So, alhamdulillah, healing in Islam is comprehensive. And I wanted just to maybe bring it back to Faris. If we only use the medical model, we're going to, diagnose him with anxiety disorder and give him medication, most likely. But if we really focus on, the human connection, focus on providing safety for the whole family, using the justice lens and working with them, and finally finding beauty in the clients that we work with, we will do much of khair for not only him, but for the rest of the family and the rest of our ummah, inshallah. And I will stop here and open it up for discussion, inshallah.
Thank you. We'll leave you with this quote that we like.
Hey, thank you so much, Dr. Thomas and Dr. Reda. I'm sure everyone agrees that was a very interesting discussion. So just like all the other sessions, if anyone has a question, feel free to write it down on a note card. They should be at everyone's table along with some pen. So if you have a question, you can raise your hand and a volunteer will come by to get it. They're standing around the room. Okay, so our first question for you is, many of our clients are incessantly consuming trauma-filled and graphic videos and are experiencing distressing symptoms due to the consumption. However, they are reluctant to stop because they feel a moral obligation to bear witness to the injustice. How do we help protect our clients from vicarious trauma in these situations?
That's so real. So real. It's interesting because it's a symptom of vicarious trauma to consume a lot of trauma media. Like that is, one of my colleagues works a lot up north in Indigenous communities. And she's like, yeah, I get home from my day at like 3 a.m. and then I watch like Law and Order Special Victims Unit, and it's like, I don't want to make light of it, but I also, that can be part of vicarious trauma. Obviously, this is a different situation that we're dealing with currently. And I think that for sure, it's this tension where people do feel obligated to bear witness, to stay informed, and yet then it's also this paradox, it's also increasing distress, right? That's like a normal reaction. So I don't know that I have a really good answer to this question. I think my perspective is that it's important to validate both of those realities, right? Why someone, it makes total sense that they feel a need to bear witness, to stay informed, to like be in solidarity. And it also totally makes sense that there's these mental health impacts of it. And I guess, how do we then open up a conversation about how much is enough? Where do they want to set the boundary for themselves? I really don't think that, again, we have to get away from that prescriptive lens, because ultimately we want, part of is empowering people to make their own choices, right? That's an antidote to the experience of trauma where you don't have a choice and you don't have a say. So part of it is actually giving people back this, okay, well, you do have a say here. Do you have thoughts, Omar, about this question?
Yeah, I agree that all of us are guilty of, overusing social media, and we want to bear witness. At the same time, I would say I try to use my anger productively, if you like. So if I see a video or an issue, what can I do about it? What's in my control? Mm-hmm. And then also try to open safe space for my wife and my children. So together we don't neglect one another while we are bearing witness to our brothers and sisters. But of course, it's very advisable to really reduce our amount of consumption, especially social media right now. Like the videos are very real and you see everything. And I don't know, I try to, only watch things that I have control over, which means, okay, if I see an issue and I reach out to colleagues on the ground or organizations that are doing work, and I say, what can I do to support?
Mm-hmm. Thank you so much for providing an answer to, I'm sure, a question that everyone is thinking about right now with what's going on. The next question I have for you is, can you provide examples of how to incorporate beauty in our practice?
I love that question. I do a lot of creative-based therapies. So I do incorporate a lot of like visual art, or I do a lot of narrative exposure therapy, in which the first part is actually laying out a lifeline where you have different symbols, flowers, candles, sticks, stones about someone's life. And so I feel Yeah, and even when we're crafting testimony, I mean, we really want it to be crisp and raw and true to the experience. But I think there's so many small ways, right? Even just in terms of celebrating every success, like you're trying to do a mindfulness practice and someone is refusing. And instead of seeing that as resistance, you're seeing that, wow, you're setting a boundary. That's amazing that you were aware that you didn't want to do that in that moment and that you're sharing that with me. And that shows me that you feel safe enough to say no to me. So I guess, I don't know, I think there's, as long as our eye is tuned in to ways, there's maybe more, I mean, obvious visual using artwork or lifeline or things like that. But then there's all these little informal ways that I think beauty shows up in these small moments of transformation. What would you say, Dr. Reda?
Yeah, I mean, I am a big fan of Rumi. So Rumi said, the wound is the place where the light enters you. So sometimes, we look at trauma and try to learn, what did we really gain out of that experience? Not advocating for people to get traumatized in order to gain wisdom and transformation, but really, like, if I look at my child and difficult behavior and I just reprimand them or punish them, really that's going to cause lots of rupture in the relationship. Rather, I try to look with a trauma-informed lens, if you like, which I believe is the way of the Sunnah and the Quran anyway, which, I will ask, most likely there is a basic need that needs to be met, or there is a missing skill that needs to be taught. So maybe rather than punishing them, I sit down with them and I do art project, or we do play therapy, or we use horses many times with the refugee children. These are traumatized horses that have been rehabilitated, and working with children who have been traumatized, and inshallah will be rehabilitated. So I find lots of joy when we work with Allah's creation. So using nature, using movements, using rituals. We have many, alhamdulillah, ways to celebrate our culture and our religion. And I was just finished with, there are two projects that I was involved with. One is my story about living in Gaza, which is, in Arabic and English, قصتي عن العيش في غزة, how to reframe the experience of children. We did the same book in Misrata, Libya. We did it in Homs, Syria. So we did it in other, parts of the world. And the second one is actually animated film that was just released. It's called Lamia Poems, which is قصيدة Lamia. This is a Syrian child who went through the refugee experience, but her teacher gave her a book by Rumi. She was able to heal using art therapy.
Beautiful. There's this, from Toronto here, this trauma-informed toolkit for the clinician that used a lot of medical illustration as well to work through these tools. So yeah. Next week, we're going to be painting stones together in one of my groups, that people can keep. So thinking about different ways of incorporating. A lot of people love our grounding supplies, like there's stuffies, slinkies, Play-Doh. I don't know. There's this incorporating playfulness, celebration.
Thank you so much. I loved hearing about beauty and the different forms it can take in your work. I think that you had some great examples and suggestions for sure. My next question is for you, Dr. Thomas. Can you please share more on the format of your group therapy that you do in your work?
Sure. We have about like 10 different groups. So there's a lot of different groups, but usually everyone is part of, the first group is called Resourced and Resilient, and it's 8 weeks. And really it's kind of 3 things. There's space for connection, sharing, just kind of, many people have felt very alone with their trauma stories, very isolated. So it's kind of breaking that. And then we do a lot of psychoeducation, like the window of tolerance, defense cascade, 3-brain. We also talk about relational impacts of trauma. And then there's skills. So tools to regulate, I guess, the nervous system and also relational regulation. So that everyone does that. And then we kind of meet with them and we see what kind of fits with their goals. And then we have a bunch of different other groups. We have a group really focused on trauma in the body. We have a group focused on healing sexuality from sexual abuse. We have a group for couples. We have a group for parenting. We have a group, a trauma in the body part 2. We have a relational group. So like we have an art therapy trauma focused group. So we have lots of different options that we can kind of tailor it's really based on Women's College Hospital's trauma program that's here in Toronto, where I did my fellowship. I'd be happy to share more if people want to talk to me afterward.
Thank you so much, Dr. Thomas. Our next question is, in community settings like university campuses where students are experiencing extreme vicarious trauma, how can religious club leaders support them, especially outside of the clinical context?
What a great question. Do you want to take this one, Dr. Reda?
Well, I'll try. I mean, I'm not very familiar with the Canadian context, but I think, it's very important that children and youth and young adults and everybody have some kind of a safe space to exercise their freedom. And right now, I think it's extremely re-traumatizing. More than actually witnessing the trauma and trying to bear witness is the fact that you cannot speak about it. So I think it's very important, at least, that we try not to take sides as colleges and don't, punish people for basically expressing their opinion, as long as they don't promote hate. So this is something that I think is very important. At the same time, I think for the Muslim, students, we need to celebrate them as much as we celebrate other minorities, if you like, and make sure that they feel as much that they belong, because this is what these countries are, claiming, that we are based on freedom and justice. And here we cannot really talk about issues that are basically and centrally about freedom and justice.
I agree with what you said. Yeah. I think that there's often this what can be even more violent is not being able to talk about violence, right? Like it's that another double whammy, right? The erasure or the invalidation of an experience. And so that can happen in the family context or in the community context, but also in an institutional context.
Thank you so much. My next question for you is about grounding exercises. For physical grounding, you mentioned that squeezing the left arm can help be a physical grounding kind of action. How does that help, or how does it work?
Could be the right arm. It could be any arm. I guess the idea is really just about bringing yourself back into the present. The idea is that hopefully there's enough safety in the here and now that you're orienting to something that isn't dangerous in the present. So often using the 5 senses, like if you're actually looking around this room and you're noticing, okay, there's no actual danger here, okay, I see that purple sign of CAMH, the windows, and so you're kind of cueing your nervous system to safety in the present. And so often using the senses is a way to help bring people back into their bodies and to the here and now. So so like planting your feet or squeezing your hands or, maybe, playing with your pen or whatever thing that might be accessible to you. Does that make sense as an answer? Yeah? Okay.
Thank you so much. Our next question is, how can rural family physicians gain more skills to support our patients with limited access to social workers, specialists, etc.?
That's such a great question. And I think that basically maybe a lot of what we're kind of trying to talk about today is that trying to foster a safe space, being acquainted with the stage-based model, maybe talking about it with your patients, doing some of those psychological first aid kind of pillars, that these are all things that can be done with very minimal resources, right? So again, removing it from it's like this highfalutin clinical issue, like usually the trauma processing work, that stage 2 work that you need all these trainings and all these different trauma focused modalities, like that's just like a little piece of the whole healing journey. So we often kind of focus so much on that, and yet that there's this whole community, family, safety, justice, like all of these other things that are actually so important. Do you have thoughts as well, Dr. Reda?
Yeah, I agree with you. I mean, I think what I did in Libya, at least my home country, is because there was very, very few resources. So we do training of trainer, we build capacity, and we make sure that they continue to have access to us after the training through supervision, consultation, even if it's from distance. So I would maybe use that approach if available. At the same time, I mean, I want to go back to the grounding, because something that I'm a big fan of is actually even grounding our heart and our soul. Many times we only ground our body and our mind, which is wonderful. But I think Rasul ﷺ and the Quran are full of ayat and ahadith that talk about how to ground our soul and ground our heart. And he was, ﷺ, the source of safety for the young Sahaba, the young companions. So even with very, very difficult questions, they came and they talked to him. And we need to be a safe space for our youth. At the same time, I think people think because the Prophet is no longer with us, that means we cannot really have access to him. When Allah subhanahu wa ta'ala, he said, وَعْلَمُوا أَنَّ فِيكُمْ رَسُولَ اللَّهِ, the Prophet continue to live with you if you continue to practice his sunnah.
Thank you. I also want to mention, I talked about narrative exposure therapy, but there are a bunch of different projects about actually implementing that type of therapy with peer counselors, right? So I've been involved in a couple projects around that. And so where actually community members are delivering that, and that is a trauma processing therapy. So there are also ways of doing more community-based initiatives.
Thank you. Our next question is about the betrayal of people you trust. So you mentioned that the antidote to betrayal from people that you trust is connection. What does that look like on an institutional level? For example, how do you connect with people that feel that they've been betrayed by the healthcare system?
Yes, every single one of my patients. It's an epidemic, like the epidemic of child abuse, right? It's a hard one, right? Because it's a paradox. We're also part of that system. We're agents in, I guess, myself working in the public system, like I'm still part of that system. And yet, I guess, part of what I guess I hope to create is a bit of a reparative space, right? And trying to actually mitigate, I think being aware of what creates institutional betrayal, and often it's being invalidated, not being believed. A lot of kids say, well, I went to my teacher, saw the bruises, or my social worker, and nothing happened, no one intervened. Or like, I've been in the mental health system and I've gotten 40 million diagnoses and no one's ever asked me about my trauma history. And so like, these are very, very common narratives. And I guess, I think we have to just, face the truth. And there's been a lot of oppression within our field. We have a dark history in psychiatry of actually perpetrating a lot of harm. And so, yeah, I think we need to kind of reckon with that and be honest about that. And then also see how can we actually create environments that are actively mitigating that. And I think for me, a big thing is about, thinking about trauma is an abuse of power. Right. And so we are in a clinical space in a power differential. So how are we actively trying to mitigate that and empower our patients to be these active collaborators, to be as transparent as we can with them around the limitations, to be trustworthy, to not overextend ourselves, because if we make promises that we can't keep, that is a betrayal, right? So actually being honest about what we can offer and what we can't offer and following up with that. And also, relinquishing this role of the expert, relinquishing that I will tell you, I know what's best for you, when every client is the expert on their own experience. So yeah, those are some of my thoughts. Do you have other thoughts, Omar?
Yeah, I really love this question. So, I mean, many organizations, including the APA here in the United States, they decided to take a stand in the current, Palestinian, I don't know what to call it. It's not an issue. It's not a conflict. It's not a war. But subhanAllah, I think we need to challenge systems. We do it politely. We do it respectfully. Because systems are made of humans. People make systems. So make sure that you challenge any practice, procedure, or policy that is not trauma-informed, and make sure that you do that in every system that you work with, not only the hospital, but also outside your place of employment, including your own family. Because I wrote a book called The Wounded Healer, because I believe that many times the healthcare system is betraying us as caregivers. And my current book is called Silence is Betrayal, actually. I'm going to talk about every kind of silence, because even the Quran and Sunnah, they became the voice of the voiceless. Allah subhanahu wa ta'ala, raised his own voice, talking on behalf of the orphans, behalf of domestic violence. And he even basically reprimanded the Prophet ﷺ when he turned his face away from a blind man. So I want you to bear witness and make sure every system, including your own family, is a place of safety. And that means don't pass your distorted trauma story to your children. If you have a trauma story, work through it and make sure that the cycle stops with you.
Hey, thank you so much, Dr. Reda and Dr. Thomas. That's all the time we have for questions today, but thank you for answering so many of them. If we didn't get to your question, I think that Dr. Thomas will be around for a little bit, so you can come and talk to her afterwards. But that concludes our session for today.